So, hello everybody. I'm going to speak today on inflection points in Parkinson's disease journey. So, we often face this challenge on an outpatient basis. What is Parkinson's disease and what is Parkinsonism? So, we need to realize one thing, that Parkinsonism is a syndrome. So, it is basically an umbrella term which is characterized by slowness, stiffness, sometimes tremor may be present. It's actually a syndrome. And Parkinson's disease is actually a disease. So it's actually the most common cause of Parkinsonism. We have other causes like atypical Parkinson's, multiple system atrophy, PSP, progressive supranuclear palsy, corticobasal syndrome, etc. We have secondary causes due to drugs, due to strokes, etc. See, one thing we need to realize is that there is no way we can actually make a diagnosis of Parkinson's disease. It is actually a clinical diagnosis. So you need to go to a neurologist and then the patient has to be evaluated. We have newer tools like DAT scans which may help you make a diagnosis, but again, it's a clinical diagnosis. So somebody has to see you, examine you, and track you to make a diagnosis of Parkinson's disease. So what happens inside the brain? Basically, what happens is, as I said, Parkinsonism is actually an umbrella term, and there's mainly a neurodegeneration which happens in the brain. So this is basically because of protein accumulation inside the brain. So we have various kinds of proteins like synucleins and like tau, and these accumulate inside the brain. They actually distort the cellular architecture and they do not allow the cells to function properly. So what happens is it actually disrupts the networks inside the brain and it causes the symptoms of Parkinsonism. So as I was saying, we have various types of Parkinson's. Primary Parkinson's is idiopathic Parkinson's disease, which is most common. That's what we see all the time. We have patients present to us with tremor, rigidity, slowness. Again, I keep telling this to all our patients that tremor is something that you see, and all our patients actually disturb because of the tremor. Tremor is mainly a cosmetic problem. When a patient comes to me on an outpatient basis, I am not worried about the tremor. The patient is worried about the tremor. If you're anxious, the tremor may increase. If you're upset, the tremor may increase. I am worried about the other symptoms of Parkinson's disease. I'm not really worried about the tremor, but the patient is mainly worried about the tremor. We have atypical forms of Parkinson's. Again, this is underdiagnosed. Almost all the patients who come to us on an outpatient basis, they tell us we have Parkinson's disease. So we need to understand that there are lookalikes of Parkinson's or Parkinsonian mimics like multi-system atrophy, PSP, or Lewy body dementia. All these look like Parkinson's disease, but they don't behave like Parkinson's disease. They progress faster. They don't respond well to treatment. You cannot do treatment like deep brain stimulation for these patients. A lot of them have speech problems, swallowing problems. A lot of them have dementia. So you need to identify that. Why is it important to identify? Because you need to prognosticate these patients well. You need to realize whether you have to aggressively treat them. If you look at Parkinson's disease, it's a 20-year-long disease. So you actually can give them a good quality of life. But at the same time, if somebody has a disease like PSP or multi-system atrophy, the quality of life is significantly affected because the symptoms spread rapidly within about 5 to 7 years, and the patient becomes bedbound or severely disabled by the end of 7 years. So you need to understand that in order to, convey all these things to the patients or the relatives. Then we have secondary causes of Parkinson's. So this is again under-recognized in our country, under-recognized amongst the public. A lot of drugs can cause Parkinson's disease. Simple drugs like your antacids. We have drugs like domperidone. People use drugs like Pan-D, Rabezell, levosulpiride. I'm not naming the brands, but what I'm trying to say is the contents that are there are the ones which can sometimes cause secondary Parkinsonism. Simple drugs which are used for dizziness and vertigo, drugs like cinerezine, or simple drugs like stemetil, prochlorperazine, which are used for vomiting, dizziness, vertigo, etc. And people keep taking it all the time. So again, that can cause secondary Parkinsonism. Another unrecognized or under-recognized cause of Parkinsonism in our country is like strokes. Patient can have recurrent strokes or stroke-like events which can cause like Parkinsonism. Then again, some patients have untreated or they don't treat their like diabetes, hypertension, etc. So they get small vessel changes in the brain which cause what we call as lower body Parkinson. So they're not able to stand, they fall repeatedly, they have freezing of gait. So again, that's an under-recognized cause. So again, you need to go to a doctor, you need to have a clinical evaluation, and then you need to make a diagnosis of Parkinson's disease. So this is something I always show up, which keeps showing up many, often, is called as a Parkinson's iceberg. What we usually see or what the patients see or what the doctors often see when the patients present to us are the trap signs. That's tremor, rigidity, akinesia, and postural imbalance, which is like recurrent falls. But what we don't see are the significant symptoms which are there like below, which are hidden, from the public, like constipation, speech problems, swallowing problems, panic attacks, loss of smell, loss of facial expression, like they lose their emotion, impulse control problems. These patients become impulsive, they have like delusions, hallucinations, lot of gastrointestinal problems, anxiety, depression, sleep problems. Again, sleep problems are under-recognized. Those who stay with patients who have Parkinson's disease may realize how much of a problem it is for them. A lot of patients have erectile disturbance, sweating abnormalities, and a lot of them end up having like dementia and cognitive impairment even. So what we see is mainly the tip of the iceberg, and that's what patients often present to us with. But what are actually hidden from the public or what are actually hidden are the significant symptoms which often, patients go to other doctors. Patients may go to a gastroenterologist or patient may go to a rheumatologist with joint pains and shoulder pains. Patient may go to a, like family physician with aches like body pains, urologist with urinary incontinence. So a lot of times these patients are misdiagnosed and then they come to us very late in the illness. So I also call this as the Parkinson's like timeline. We need to understand that Parkinson's starts many years before the onset of motor symptoms. If the motor symptoms start here, the symptoms of Parkinson's disease starts many years before that. You may have loss of smell, you may have constipation, you may have bladder problems which start up to 20 years before the onset of the disease. And then, you have the progression of the premotor symptoms. And then it's at this point of time that the patient comes to us, where you have tremor, rigidity, and akinesia. And then you can see it's another 20 years till the patient becomes like bedbound. So you have, a good lifespan where you can treat these patients. And you need to identify, you need to track these patients. If you don't treat them well, they would become like disabled by about like 5 or 10 years. So if you're able to track them properly, you will be able to treat them well and you will be able to like give them a good quality of life. And this is something you need to understand, so that if you're able to track these patients over a period of time, you're able to counsel them well, you're able to give them proper medications, most patients would have a good quality of life. So why does tracking matter? Tracking is important because, as I said, patients have both motor and non-motor symptoms. The motor symptoms are very easy. Patients often present to us with the motor symptoms. All of you all can recognize. But the non-motor symptoms are also equally important, and that's the one which is invisible. These are the invisible symptoms. You have sleep problems, mood problems, constipation. Anybody who's had a patient with Parkinson's disease with constipation, that's one of the most troublesome symptoms. I've had patients calling up at 2 o'clock at night, 3 o'clock at night, saying that they're inside the bathroom for hours, they're not coming out. Do something. And it's like very frustrating even for the relatives, for the doctor, how can they help out? All these would affect the quality of life. Again, like BP drops, these patients may not be having adequate water, because they are worried that they have to get up at night multiple times to go for urine. So they stop drinking water at 4 or 5 p.m. in the afternoon, and then they are like dehydrated. There's a drop in blood pressure, so you need to understand that. Again, tracking, it's very similar to tracking of blood pressure and sugar, so it will help prevent complications. So what happens in the brain? So inside the brain, basically there's a loss of dopamine. So why is dopamine important? So dopamine is the fuel that actually moves your body. So in simple local language, it's very similar to the petrol or the gas that runs your car. So you may have the fittest body, but if you don't have the dopamine inside your brain, it's not going to run. So you need to understand that. But you have other chemicals which are also affected, like norepinephrine, which are associated with fatigue and BP regulation issues. Then there are protein accumulation inside the brain, like Lewy bodies and alpha-synuclein, which cause the progression of the symptoms of Parkinson's disease. So for example, you may have like drop in like blood pressure when a patient stands up. This leads to dizziness, and this may lead to falls. So you need to identify that. If you don't identify that, patient may present to you saying that every time I stand, I'm feeling very dizzy. Every time I walk, I'm feeling very dizzy. But if you're not going to check the blood pressure when the patient is standing, you're not able to, means you would not be able to treat these patients accurately. So what is an inflection point? So inflection point is basically a change in the curve. So why is it very important? So you need to identify that, a patient with Parkinson's disease is going on for some time, and then something happens which worsens the disease or which causes a change from the baseline. We need to identify that inflection point, because from that point onwards, the patient is going to deteriorate. So when I look at it from a clinical perspective, there are about 3 or 4 inflection points which are very important. And those 4 inflection points are, one is falls and freezing. Second is speech, swallowing, and breathing problems. Third are the non-motor symptoms. And fourth are the medication changes. And each one of them is important, and I'm going to tell you all about that. So the first inflection point, which is very important, and I keep telling this, patients, if somebody asks me, am I going to die with Parkinson's disease? I tell them, you're not going to die with Parkinson's disease, because you're going to have the disease for the rest of your life. But there are only 2 ways that a patient with Parkinson's disease may have a mortality. That is, patient may be walking, patient may fall down, break a bone, become bedridden, have a bed sore or some problem, and then patient may not make it, that's one thing. Second is, the patient actually has speech and swallowing problems, and the patient chokes, patient has an aspiration pneumonia, patient goes on a ventilator, and then patient is not able to survive. So if you're able to treat these 2 important points, you would be able to give them a good quality of life. So the first is falls and like near falls. So this is something which is very disabling. Anybody who's had Parkinson's would realize, they are scared of falling. They have a fear of falling. When they see narrow spaces, when they see a lot of people, they start walking more slowly. They start holding on to people. They start holding on to things. And near falls are a warning sign. So a lot of times in my outpatient clinic, I ask the patients, are you all falling? Do you have a tendency to fall? It's actually a sign that the patient may be under-medicated. So you need to identify that. Okay? And the patient needs to report every falls. If you're not going to report the falls, a lot of times they may say, the patient slipped on water, or the patient was just walking and fell down. And patients may hide it. The relatives also will underplay it. So that's one thing we need to understand. Falls are important to recognize. Report every fall to the doctor. Second is, there are certain triggers for freezing. So if you see a patient with Parkinson's disease, patients always tell us this, or the relatives tell us, when he's walking on the road or when he's walking outside on an open space, he's perfectly fine. But when he's at home or when he's in the bathroom, he freezes, he's having a difficulty to turn around. So that's one thing we need to identify. Patients struggle in narrow spaces. They may have problems with respect to turning around in a narrow space. So if you ask them to turn en bloc, they would just fall down. And again, if you are multitasking, the chances of freezing increases. If you're anxious, the chances of freezing increases. If you're fatigued, the chances of freezing increases. So that's why if you tell them, hurry up, we have to go for a wedding, they're not going to reach. You have to prepare them 1 hour in advance when you're going for a wedding. Or at the end of the day, you'll see that patients may get fatigued and then they start, freezing. And the third symptom is like dizziness. Now, this is something we need to identify. A lot of patients with Parkinson's disease complain of unexplained like dizziness. They say, I'm feeling, chakkar aa raha hai. Or they are very dizzy, they are having imbalance, they feel like they are about to fall. You need to see how these episodes are triggered. Number one, are they feeling off balance? Is it because of freezing? Is it because of falls? Or is it because of a drop in blood pressure, what we call as postural hypotension? Our next inflection point is swallowing. So again, we need to identify red flags like coughing with water, choking, with a wet, gurgly voice, unexplained weight loss. Now, unexplained weight loss is a very important symptom, I always ask this. I always measure the weight when patients come to our outpatient department. Recurrent chest infection. If a patient is coughing, again, underplayed a lot. Every time they cough, you need to realize for swallowing, it should be 10 on 10. Even you choke once, you can aspirate. You need to identify that. You need to make it very clear. We have various ways by which we can improve. We have like swallowing therapy. We can change the consistency of food. We can give soft smash diet. Again, a lot of patients also complain of speech problems where you have soft voice. So again, with Lee Silverwind, like voice training, it helps. And it's very, very beneficial. Some patients also complain of breathing problems when they have, associated with Parkinson's disease. So this is associated with the wearing off episodes. This may be associated with anxiety. And a lot of them may be having breathing problems when they have aspiration. So this is also under-recognized. So if you are having swallowing and speech problem, also look at their breathing. Again, some patients who have dyskinesias also have breathing problems, or when the off period starts, they may have breathing problems. So you need to identify that. So we have to track the third inflection point. Those are the non-motor symptoms. So that's sleep problems like acting out in sleep, that is RBD, fragmented sleep, they may not be sleeping well. Again, sleep is very important to the brain. Sleep is like the garbage truck of your brain. It cleans your brain at night. So if you're having a fragmented sleep, the daytime you're going to have a lot of problems. You're going to have excessive daytime somnolence, it will increase the risk of falls, increase the risk of dementia. You need to identify that. And like mood problems, depression, anxiety, and apathy are very common with Parkinson's disease. Cognition, this is again under-recognized. So cognition, patients may have, some of them may have cognitive impairment, hallucinations, and confusion. Some of them may be because of the medications. Again, it needs to be identified. And autonomic disturbance like urinary urgency, constipation, and like dizziness and standing. The fourth inflection point, which is the last one we need to track, is the off time. This is something we don't speak about. So you may be taking your medication 3 times a day, 4 times a day, or 5 times a day. Understand one thing, you need to be on for most of the time. If you're off on the medication, that means you're under-medicated, or you probably don't have Parkinson's disease. So you need to track the off time. And on time means you're having a better control of your Parkinson's disease. Off time means the symptoms are more, prominent. The next thing you need to track is the dyskinesias. A lot of patients have, what we call as peak dose dyskinesias. So they have a lot of excess movements. You may see a lot of patients with Parkinson's disease, when they take the medications, they have a lot of like twisting and turning. It may be a peak dose dyskinesias. So if the patient is having a lot of dyskinesias, it indicates that the patient is over-medicated. So you need to bring down the medication. And then you need to look for the side effects of the medication. So that's another thing, the more you take the medications, or the more are the dosages of the medications, the greater are the chances of side effects of these medications. So you need to track them for the side effects. So very simple. It's all three points that I've actually put up, three things. And if you're able to track these, it should be very easy to manage your disease. So you track the patterns, adjust the medication, and then you consider advanced options if all this fails. If medications fail, then you have DBS, you have levodopa, carbidopa, infusion gel, then you have apomorphine therapy. All these are part and parcel of advanced treatment for Parkinson's. So we have, an OPD tracker. It's very difficult to track all the symptoms of Parkinson's disease, very cumbersome. So in the olden days, we used to have the Parkinson's diary. So 8 o'clock, 9 o'clock, 10 o'clock. So you write the medication, then you see how the patient is doing over a period of time. It's very difficult. What we have out here is a Parkinson's, is a OPD tracker, where you just see whether these 4-5 inflection points are looked at. You look at falls, you look at near falls, freezing, you look at choking, you look at like dizziness, and you look at confusion and hallucination. And then you see whether you're improving over a period of time or you're actually deteriorating. And this would actually help you to track the symptoms of Parkinson's disease. For a patient, this is far more easier to do than mentioning the entire iceberg. If you have to go through the entire iceberg, you yourself would be like drowned in it. So better than that, just look at the important points, track it over a period of time, and that would give you a clue as to whether you're improving or you're remaining the same, or you're showing a deterioration with respect to the symptoms of Parkinson's disease. So what do you do when you spot an inflection point? So first is you start physiotherapy. So for falls, you start physiotherapy, and it really helps. So this is something which is, again, under-recognized. So physiotherapy does help. There's enough data and evidence. Again, speech and swallowing therapy helps. There's enough data and evidence. You track and adjust your medications. Again, that's with your doctor, you would be able to sit down and help. And lastly, when the symptoms of Parkinson's progress, then you have to consider advanced therapies like DBS or levodopa, carbidopa, intestinal gel, or apomorphine therapy. So in summary, it's important to recognize the inflection points. Remember that you have both motor and non-motor symptoms. So I keep telling this again and again to patients. Tremor is not important. Tremor is not. Tremor is just a cosmetic side effect. But all the other things are more important. A fall is more important. Rigidity is more important. Stiffness and slowness is more important. Non-motor symptoms are more important than tremor. So don't focus on the tremor so much. You would not be able to control the tremor. Not many therapies improve the tremor. But we can improve the other symptoms of Parkinson's disease. Focus on the hidden risks. Identify that, focus on that. Identify them, evaluate them, and then treat them adequately. And I'm telling you, if you follow this, guaranteed around 80 to 90% of patients would have a good quality of life. We have patients whom we've seen well into their 70s and 80s. They're independent, doing well. They're monitoring their disease well. They're just taking their syndopa, levodopa, carbidopa, and they're leading a good quality of life. I mean, it's just like any other disease. You may have hypertension, you may have acidity, you may have like diabetes. It's very similar to that. You just have to treat it like that. Take the medications properly, identify the trigger points, and then you could lead a normal life. I would like to thank you all for giving me an opportunity to speak. Thank you again.